going to talk to you today about our 3-year experience with our Hernia Center of Excellence. I have disclosures. I do some speaking and teaching for Intuitive Surgical and also do some consulting work for a company called Deep Blue Medical. So what's the Center of Excellence? So about 5 years ago, well, now it's probably 6 years ago, Dr. Lewis and I were having an intense meeting one evening on the back of a Boy Scout bus and talking about what we wanted to do with our practices, where we were going. And at the time, some of you remember, we were already keeping our data. We're trying to see if we're doing a better job. We really, even at that time, felt like data was really important to improving and doing things better. And so we started talking about this idea of a center of excellence. Quite honestly, the first place I heard about that was from Dr. Alan Butts, that all of you probably know. But he was the one that brought that to my attention many, many years ago, and that was his dream. So, when we started talking about this, we started looking for solutions. And SRC is the Surgical Review Corporation. They've done Center of Excellence work for many, many years. They started back in the early 2000s with bariatric surgery. And those of you who are familiar with the amount of data collection and things that the bariatric guys do, it's extensive. And so being able to build off of that experience, they started these centers of excellence with many different specialties. And hernia was one of them. So when we started looking into this, it really seemed to fit what we were doing. We had already started doing some, we didn't call it a robotic steering committee at the time, but that kind of a leadership type meeting. We had already started collecting data in the operating room. And that was when we first started talking about a lot of the OR efficiency stuff and things that many people in this room have been really key in getting us to improve. But that's where the Center of Excellence stuff came from. It was, how do we come up with a structure to improve our quality and improve our patient outcomes? And really, it wasn't so much us trying to get to a place. It was, okay, we really feel like we're doing a good job here. How do we, number one, show that? And number two, standardize that so that we can reproduce it again and again. And that's where the Center of Excellence came in. What we've always said that we wanted to make sure we didn't have was just a hollow marketing scheme. Anybody can take a banner and throw it up on the front of the thing out there and say, we do robotic, whatever surgery. That's easy to do. And it doesn't require any data or any proof. You can put a sign out there today. But what does require that is making that safe, high-quality care of patients one of your, mantras for what you're going to build your program around. And that's really what we wanted. We wanted improved patient outcomes that were reproducible. So we signed on to the Center of Excellence type stuff. So, and there's been a lot of talk, especially in the hernia world, but in other worlds about, what's a Center of Excellence and an excellent surgeon, and, people who don't really understand it really poo-poo it a lot and just make fun of it because they don't understand that what we're really doing is a whole lot of data work to look at patient outcomes. This is a meta-analysis that came out last year, actually just last month, looking at both robotic inguinal hernia repairs and robotic ventral hernia repairs, and showing that there's a lower recurrence rate, lower use of opioids for robotic inguinals, and lower conversion rates, lower post-op complications in ventral hernias, despite the fact that both ventral and inguinal hernias had longer operative times. The reason I put this up here is because what we're seeing is kind of this transition of robotic surgery the exact same way we saw a transition of laparoscopic surgery. I kind of the same experience that Dr. Dillard talked about, when I was in residency, we were still doing lots of open surgery. There were still people in Northeast Georgia doing open cholecystectomies when I came here. And so I got to see that whole, laparoscopic transition, and when laparoscopy was something new and unique, and, you only had like a couple towers in the whole hospital, and you had to roll them in on the carts that, like you used to have the VHS, video players on, and that was how we did laparoscopic surgery. Then that was something new, and everybody said, oh, this is just a fad, it's going to go away. And then we transitioned to where, that was an everyday thing. And so over the past 10 years, we've seen the same thing with robotics. Robotics was thought of as some little niche thing that only a few people did, and it's only for certain things. And now you're starting to see more and more people do it, and people changing their practices to it. In the classes that I teach people when they're first starting out. I have people all the way from, I just finished residency last month, all the way to, I've had a 62-year-old and a 63-year-old, just like Dr. Singh's, 70-year-old partner. These surgeons have been practicing for 30 years. They are good surgeons who see that, hey, this is the next step. This is how we continue to improve patient outcomes. So this last point is what you're going to see the difference of in the next 10 years. Now that it's becoming accepted and we've shown that it's got better outcomes, now we get people through the learning curve. Because just like any other tool in the operating room, whether it's a C-arm or a new stapler or anything, the robot has a learning curve. So, and you guys that work there see us all struggle through that, all the time. You've got some of us who are pretty quick at it and have done it for a little while, and then there's others who are just starting out and are super slow, and you're like, oh my gosh, we got to go through this again. But it does pay off in the end. And luckily, the robot has a little bit shorter learning curve than most other things that we've had to learn in our lives. So I think 10 years from now, that last statement on there, that'll be gone. And we're already seeing that in like robotic gallbladders, where you can see, once people get over 100 cases, their laparoscopic and robotic times are about equal. So looking at some data from the past 3 years, we started collecting data in fiscal year 19. So you're going to see some 19 data up here, but it's really 20, 21, 22, 23. And we started our Center of Excellence, at least the Hernia Center of Excellence, on March 8th, 2020. Those of you who were here remember that 10 days later, our whole operating room shut down for COVID. So it was a great start. We timed it perfect. It was awesome. But obviously it didn't hurt our numbers in 2020 because we killed it as far as surgeries were going. We've increased every year. Last year, we did a total of 1,473 hernia cases here at Northeast Georgia. When we look at all those hernia cases, I told Dr. Lewis, I put this up here for him because he is number one here for the October 22 to September 23. But we've got a number of surgeons that do hernias at the hospital, including Dr. Dillard, and did some hernias, but sometimes you get some others. It's where you got to go back and look at your data, but we'll figure that out. But this is just looking at volume, and volume's one thing that we look at to see how people are doing. Just like a couple of others have pointed out, volume a lot of times does translate to better patient outcomes, but it's not the only thing. So here's volume of inguinal hernias, and we're able now to look at hernia center surgeons versus those who are not in our hernia center of excellence. We've got some inclusion criteria as far as what you have to do to be in the hernia center of excellence. And the main thing is, number one, commitment to data, number two, commitment to teaching, and number three, a commitment to being able to take care of whoever comes through the door. Meaning, you have to be able to do the full breadth of hernia surgery: open, laparoscopic, robotic, ventral, inguinal, other locations, lumbar, peristomals. We want to be able to take care of whoever comes through the door. So those are kind of those inclusion criteria. So when we look at hernia center versus non-hernia center, even for inguinals, we're about 100 or so more in inguinals just by volume. Ventrals, little over twice the volume that the Hernia Center of Excellence surgeons do versus everyone else. So percent of ventral hernias done by Center of Excellence surgeons. Center of Excellence surgeons did 65% of all the hernia surgeries over that 3 years. Everyone else did about 34%. So what's the relevant data to collect? Number of cases is important, but we also look at outcomes, surgical site infections, surgical intraoperative complications, returns to the OR, readmissions, recurrence rates. The Centers of Excellence employ 1.5 FTEs of people that really just do data. Brianna and Sheila both do a great job for us and do all the legwork on this, and along with some other people on their team. So we really appreciate all their work. So looking at some of those things, reoperations, less than 1% for both groups. All inguinals reoperations of 0.5%. Which is awesome. Reoperations with ventral hernias, again, less than 1%. 0.7% reoperation rate for all of them. The readmissions, again, 0.96%, so less than a 1% readmission rate for inguinal hernias. And ventral hernias, it's 1.8%. All of those are extremely low and really good. So, what are people being readmitted for? Most of the time, bowel obstruction ileus is usually our number one, followed by cardiac stuff. And then you see that this includes any type of readmission. So, we had 3 people over this past year get admitted with trauma within the first 30 days after their hernia surgery. So, it does include everything. And we follow those by, how many you've done compared to what you've done. And then what's the percentage, So, and this makes sense. The 5 people over here, those are all your trauma patients. Those are all your ACS surgeons. So, of course, you're going to expect them, if they're doing hernia surgeries, you're going to expect that those are probably either traumatic hernias or somebody who's got other things going on. Obviously, their readmission percentage is going to be higher because they've got a whole lot more going on a trauma patient than I do in a elective inguinal hernia patient. So that kind of data makes sense. So length of stay, this is looks crazy like this, but 0.14 days for ventral hernias versus 0 days, meaning we really try and get people out of the hospital. And then this is our case volume again, looking at total number of hernia cases over this past year. The thing that I point out in this is for 2023. And some of you don't know, but the AMA changed the coding for ventral hernias this past year. So for the year of 2023, we had a different coding scheme for how we coded our hernias. The key to that was they made certain hernias inpatient-only codes, meaning they mandated that if a patient had these procedures, they had to be done as an inpatient, which was really unfortunate because in the previous year, in 2022, the Hernia Center of Excellence surgeons had a 98.2% outpatient surgery rate. So 98.2% of our surgeries, including transverse abdominis releases, component separations, all of that, were all outpatient. And then this past year, that dropped down to 90%. And that was really because of that coding problem. So I'm not sure why the AMA wants people to be inpatients. And a lot of us wonder about who those people are around the table making those decisions, because a lot of times it's not people like us, it's people with a lot more gray hair than what we have, even though I've got quite a bit. But it really set us back in what we were trying to do from getting people out of the house. So again, 98.2% versus 90.5%. So, all right, so ventral hernia recurrence rates. So if we look at this is our all non-inguinals, this is hernia referral center, this is non-hernia referral center. So 1.75% to 1.8%, both very low recurrence rates and very similar. So that was awesome from both those groups. I really had to ask Sheila about this because most of the time when you read papers about hernia recurrence, depending on the group of patients that you're talking about, those recurrence rates run from anywhere from 5% in some papers up to 15% in papers that you're talking about recurrent hernias in complex patients. So when we look at all of our patients and we start talking about a 1.75% recurrence rate, that's awesome. That means that, and this is looking at all 5 hospitals in our system. So even if they had their first surgery here and then they showed up in Brazelton with their recurrence, we would catch that. So we're really proud of that 1.75%. This is, again, percent of recurrences over the course of, percent of recurrent ventral hernias over the course of each year. And although that's not the right data, that's not what that shows, because that's showing 17%. Sorry about that. That's probably the wrong thing. So recurrence rate, 1.75% to 1.8%. The other key data point here is that during that 3-year time period, there were 353 recurrent ventral hernias that were done here in Northeast Georgia. Of those 353 recurrent hernias, 281 of them were done by Center of Excellence surgeons and only 72 by non-Center of Excellence surgeons. So despite doing 4 times as many recurrent ventral hernias, the Center of Excellence surgeons still had a recurrence rate that was lower than the non-Center of Excellence surgeons. Again, inguinals, hernia referral center, 1.33% recurrence rate. Non is 1.65%. And again, the inguinal hernia, 233 recurrent inguinal hernias done. The Center of Excellence surgeons did 66% of those. So despite, again, doing 2 out of every 3 recurrent inguinal hernias, we still had a lower recurrence rate by 0.3%. This last stuff is on actual hernia codes for this past year. Although there were some bad things about it for readmission stuff, or for admission stuff, what it did allow us to do is to stratify our hernia patients by size of defect, because now that's what the coding is based on. It's based on whether it's primary recurrent and then the size of the defect and whether it's incarcerated or not incarcerated. I was only able to get my own coding data so far, but I hope to add my other 2 partners in here too. But so this is my coding data and versus my group. So this is COE surgeons. Had 22%. Did 22% recurrent hernias. 22% of my surgeries were done on recurrent hernias. Non-COE was 9%. So 25% of all my surgeries over the past year were on hernias which were greater than 10 centimeters in size. So 1 out of every 4. And I'm sure Jerry can attest to that. The 26% of all my hernias were recurrent. Versus 9% for non-COE surgeons, and 24% of all the hernias that I did required some type of component separation, which in my population usually means that they had a hernia width which was greater than 7 centimeters, versus 0% no component separation for the non-COE surgeons. So why were our hernia outcomes better? Volume's one thing. I usually say, if you're the right rear tire changer, you're probably really good at changing right rear tires, right? So, you do get better with volume. The other is focus and specialization of your practice. So when you concentrate on hernias and when you go to, you start teaching hernias and you go to conferences on hernias, you're probably going to get better at doing hernias. And the last is really that commitment to data and outcomes. It's really committing to, let's see if we're doing a better job, and if we're not, figure out why we're not. So I think those are all very important. So, going back to the reason we did this in the first place, the reason we did this is to deliver the safest, highest quality surgical care to our patients. And I think by collecting that data, following the data, and changing your practices based on outcomes, you can offer safe, high-quality care to all of our patients. So conclusions, COE surgeons had less inguinal recurrences, less ventral recurrences, less readmissions, and less length of stay, despite increased hernia size and complexity for all those patients. So it does make a difference in patient outcomes to be in a hernia center of excellence. So thank you very much. Any questions? Yep. Otherwise, people online can't hear. I think we have like 25 people on Zoom right now, so good turnout from them too.
Thanks, Dr. Copper. But no, I appreciate all the input and the data. That was great. What is your exclusion criteria? I'm curious for like your patients that come to the Center of Excellence. So, for example, a lot of times for the community hospitals that are not a part of the center, obviously, we get patients and we can't always turn them away based on incarcerated bowel or what have you, pain. So do you have any exclusion criteria for patients that are referred to you?
No, I mean, that's really and that's what we've tried to tell everybody, especially when we started the Hernia Center of Excellence. It was really to show kind of our community, as well as our referring physicians and all of them, that, hey, listen, you don't need to send any of these patients anywhere else. It used to be when we started out, we'd send people to Emory with the big open hernia. We'd send them up to Greenville, to Alfie Carbonell and those guys if they had the skin graft over bowel type of hernia or something that required a component separation. And then as Dr. Lewis and Dr. Mullis and I kind of improved our skills and got those kind of skills, we really wanted to show people that, hey, listen, you don't need to send people anywhere. So we really have zero exclusion criteria. Nice. Anybody who walks in the door, we're going to take care of them here for no matter what kind of hernia they have.
Thanks. And one more question.
Yeah.
What is, and I might have missed it, like what are the percentages as far as like the total hernias that you all do, like 2,000, like how many is like open versus robotic versus laparoscopic?
Good. So in ours, it was, and I should put that up here, but in our data, it's if we look at ventral hernias, it's like 99%, 98.7% or something robotic, and about 1.3% open. We don't do any laparoscopic ventral hernia repairs. I feel that closing the defect is extremely important and has been shown to decrease recurrence rates and have better patient outcomes. So if you believe in closing the defect, then the best way to do that is either open or robotic and not laparoscopic, and we don't patch hernia defects anymore.